Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Hello dear students. Today this is our surgery lecture number 6. Gastric Neoplasms, benign and malignant tumors. In these lectures, we will see benign tumors, malignant tumors, carcinoma of the stomach, sarcoma of the stomach, and upper GI bleeding. So let's start with me. Gastric neoplasm, benign tumors. These benign tumors are rare in comparison to malignant tumors of stomach. That may be the polyps, Leiomyoma, Lipoma, Neurofibroma, and Ectroxic pancreas. First is the polyp. In the polyp tumors, benign tumors, there is a hyperplastic polyp and adenomatous polyp. Hyperplastic polyp is sessile, solitary in antrum or fundus of the stomach, and adenomatous polyp is maybe the sessile or pedunculated, that is the papillary or villous in character. It is true neoplasm and is potentially malignant. The treatment of these benign tumors of stomach is by fiber optic gastroscope, totally excised by the snare or cautery, and is to be sent for histopathological examination. Third is Leiomyoma, commonest tumor. These are the commonest tumor of the stomach. Mesodernal origin, represents about 80% of benign tumors of the stomach, and treatment is small lesions can be shelled out by the gastric wall. Third is the ectopic pancreas. Lesion is usually submucous, mostly seen in antrum or pre-pyloric region. Tumor may be projected into the lumen of the stomach. Malignant tumors, that is the carcinoma of the stomach. You are seeing this diagram on your screen, which shows the stomach 10% in the cardia, 12% in the fundus, and 18% in the body, and 50% of antrum. There is a chances of this percentile of the carcinoma in the stomach, and only multiple carcinomas of the stomach is 3%, and diffuse carcinoma of the stomach, total stomach, is only 7%. Okay. Now the etiology: diet, increased salt consumption is associated with say of the stomach, carcinoma of the stomach. Cigarette smoking is predisposing factor. Environment varies country to country. USA is number 1 and Japan is number 2 for environment. These countries are very prone for carcinoma of the stomach by the environment. Age and sex: rare below the age of 30 years. Between 50 to 70 years is common. Male is more affected than female, and the ratio is 3:1. Heredity: certain families show the strong predilection. Predisposing factors of the malignant tumors of the stomach are: first is the chronic atrophic gastritis. Normal gastric glands are decreased or absent, so hypo or achlorhydric atrophic gastritis coexists with intestinal metaplasia, in which gastric mucosa is replaced by mucosa closely resembling that of the small intestine. Second is the pernicious anemia. 10% of such patients develop malignancy of stomach. Chronic gastric ulcer, new growth of the stomach, cauliflower growth of the pyloric antrum. Benign polyps in association with atrophic gastritis may turn to malignancy. Adenomatous gastric polyps are also pre-malignant conditions. Hypertrophic gastropathy, that is the Meniere's disease. Giant hypertrophy of fundic mucosa with cystic changes in the crypts. And sixth reason is the other six predisposing factors are the other possible factors like smoked food, means you are smoking while eating, very hot and ice drinks, very chilled water is drinking, over smoking, excessive consumptions of alcohol, constant nervous strain, lack of vitamins, especially vitamin A and C, and malnutrition. Pathology of the carcinoma of the stomach: and the commonest site of adenocarcinoma mostly develops from mucous cells of the stomach, and majority develops in the pyloric and antral region. Microscopic types of carcinoma of the stomachs are ulcerative, proliferative or cauliflower type, and leather bottle stomach or Leiomyoma plastica, that is the serous carcinoma. First, macroscopic types are ulcerative, most and commonest type of the carcinoma of the stomach, infiltrates widely and rapidly. Second is the proliferative or cauliflower type, that is the rounded soft tumors with broad pedicles which project into the lumen of the stomach, composed of columnar epithelial cells. Third is the leather bottle stomach or Leiomyoma plastica, that is the serous carcinoma of the stomach. Starts at the pylorus and spreads slowly towards cardia, also with much fibrosis. There are two types of leather bottle stomach carcinoma of the stomachs are one is localized and second is diffuse. Localized pyloric region develops in the pyloric region, and diffuse form starts at pyloric region infiltrating and the submucosa and subserosa layer of the stomach. Stomach eventually becomes shortened and contracted and transformed into the leathery rigid tube incapable of being distended. So this is called leather bottle stomach. Fourth is the colloid or mucoid carcinoma of the stomach, merely a gelatinous degeneration. Fifth is ulcerative cancer, and sixth is the carcinoid of the stomach. Only 2% of all carcinoid tumors are seen in stomach. Microscopic types of the carcinoma of the stomach are adenocarcinomas, squamous cell epithelioma, adenocanthoma. Adenocarcinoma, commonest variety, presence of large amount of mucin. Squamous cell epithelioma, situated at the lower end of esophagus. Adenocanthoma, very rare variety of the gastric carcinoma, and admixture of glandular or squamous cells. And the spread of these carcinoma of the stomachs are through the direct spread, through lymphatic spread, through blood spread, and through transperitoneal spread. These are the four types of the spread of the carcinoma of the stomach. First, direct spread in the stomach wall to the adjacent organs, neighboring viscera by direct spread, which is localized nearby the stomach. Lymphatic spread occurs by the embolism or by permeation. Third is the blood spread by malignant cells enter into the bloodstream and metastasis in the other organs like liver and other. Fourth spread type is the transperitoneal spread. With cancer cell reach the peritoneal surface of the stomach, malignant cells are soon freely discharged into the general peritoneal cavity in the general peritoneal fluid and give rise to carcinomatous peritoneum. Now the clinical features of the carcinoma of the stomachs are epigastric pain and indigestion, loss of weight, hematemesis, abdominal mass, anorexia, vomiting, melena, dysphagia and diarrhea. Special investigations is to be done in the carcinoma of the stomachs are routine blood investigation, in which we can find the decreased hemoglobin, decreased RBC and increased ESR due to the malnutrition. Second is routine stool exam, found the occult blood present in about 80% of cases of carcinoma of the stomach. Gastric function test should be done. Gross hypochlorhydria and achlorhydria is to be seen in this gastric function test. Barium meal X-ray, irregular filling defects finding in favor of carcinoma of the stomach. Endoscopy, whenever a lesion is detected by gastroscopy, biopsy should be taken. It is mandatory. Exfoliative cytology, examination of cells detected by washing of the stomach or gastric lavage. 7 is tetracycline fluorescence test. Growing a carcinomatous cells absorb tetracycline quicker than normal cells and are stained yellow due to the color of the tetracycline. 8 is the serum pepsinogen, first level, specific marker of the intestinal metaplasia. This level would greatly enhance our ability to identify those high risk of the developing carcinoma of the stomach. 9th is the CT scan. Determination of the extent of disease may assist, and the treatment of the carcinoma of the stomach is surgically radical operation, total radical gastrectomy, upper radical partial gastrectomy or lower radical prostatectomy where the carcinoma of the stomach is situated or developed. According to that, and if there is no metastasis, then according to that these three types of operation is to be chosen. Now the palliative operations for gastric carcinoma is not suitable for radical operations, then some sort of the palliative operations. Palliative resection of the growth, antral exclusion operations for feed adherent irremovable growth, gastrojejunostomy for irremovable malignant lesions of the antrum and pylorus, and for the jejunostomy, Marvedel jejunostomy, rubber catheter is to be put in the stomach, and gastrostomy. Now the next point is sarcoma of the stomach. In comparison to carcinoma, it is very rare and constitutes only 1% of gastric carcinoma. This contributes only 1% of total gastric carcinoma. Lymphosarcoma, commonest variety, respond to radiotherapy and treatment is partial gastrectomy along with the tumor. Second sarcoma of the stomach is leiomyosarcoma, usually arises as malignant change of leiomyoma. Leiomyoma is converted into leiomyosarcoma. Neurofibroma, fibrosarcoma, very rare and malignant tumor of the stomach. Now upper GI tract bleeding, it is very common. Emergency causes may be local or general. First, local causes. One is esophagus, second is stomach or duodenum, and third is the small intestine, in which the upper GI tract bleeding is seen. Now the esophagus reasons are gastroesophageal varices. It is very common. Reflux esophagitis, hiatus hernia, Mallory syndrome, Barrett's ulcer, polyps and carcinoma, achalasia or foreign body stuck into the esophagus. Now the second local cause is stomach or duodenum, chronic duodenal ulcer, which is contribute 33%, chronic peptic ulcer contribute 33%, chronic duo ulcer contribute 20%, multiple erosions contribute only 10 to 25%, and tumors, polyp and carcinoma. Third local cause is small intestine. Through the upper GI tract bleeding is seen. One is the Meckel diverticulum, Peutz-Jeghers syndrome, polyp, vascular malformation, and various tumors. B. General causes of the upper GI bleeding is hemorrhagic disorder. Second is ingestion of drugs and salicylates and alcohol. Third, in hemorrhagic disorder there is thrombocytopenia. Maybe there is a purpura. Maybe there is chances of hemophilia, pernicious or other anemia. Ehlers-Danlos syndrome, DIC, coagulopathy, liver disease, periarteritis nodosa, ingestion of drugs, steroids and NSAID. These are the general causes of upper GI bleeding. Diagnosis: assessment of hemorrhage, difficult to assess the degree of blood loss. Second is the assessment of cause to assess the probable cause of the bleeding. Now investigations in upper GI bleeding is endoscopy first, diagnostic and therapeutic both. Second is radiology, straight X-ray should be done. Contrast study is to be adopted by barium studies. Angiography, two main reasons for performing angiography: to locate the source of bleeding where this is unknown, to stop the bleeding by selective infusion of drugs like vasopressin. Embolic materials such as sterile absorbable gelatin sponge, that is the steric sponge, is to be used. Lyophilized human dura mater, Lyodura, steel coils, acrylic polymers, detachable balloons is to be used in the lower esophageal, that is esophageal varices bleeding. Fourth is the isotope studies. Technetium labeled or radiochromium labeled red cells or technetium labeled sulfur colloid can be injected IV intravenously. Fifth is the ultrasound and CT scanning, not very useful in acute upper GI tract bleeding. Management depends on the cause of the bleeding. Management or treatment should be adopted according to the cause of the bleeding. Okay student, here is the end of our surgery lecture number 6. Thank you.